I'm Dr. Aaron Miles, a coloproctologist, and if you live with persistent bloating or excess gas, I want to give you practical, evidence-informed steps that often cut symptoms dramatically. In the next few minutes, I'll explain what usually causes gas, why most of it isn't what people expect, and exactly what you can start doing today to feel better. If this helps you, please subscribe, like, and share so others struggling with the same problem can find it. If your symptoms are severe, getting worse, or accompanied by weight loss, blood in the stool, relentless abdominal pain, persistent vomiting, yellowing of the eyes, or high fever, stop and seek immediate medical evaluation. When patients sit across from me, their first word is often embarrassed, then uncertain. Is this normal, they ask? The short answer? It's common and often manageable. The longer answer begins with a key point I say to everyone. Studies suggest that roughly 1/5 of the gas people notice is produced by bacterial fermentation in the colon. The majority is related to swallowed air, called aerophagia, or to how the gut moves and holds gas. That matters because it changes what we try first. If most of what you feel is from air you swallow, changing habits around breathing, chewing, and drinking can make a big, fast difference. If fermentation is a bigger factor, targeted dietary shifts and cautious use of probiotics or enzymes can help. Either way, the path to relief usually starts with simple behaviors, not pills. I remember a patient I'll call Maria, in her late 30s, who described a daily tightness across her lower ribs after meals that made her avoid social dinners. She showed me the place on her abdomen where her waistband had cut into her. "I feel like an air balloon," she said, and the image was useful. It's a clear picture of the problem: too much air and poor clearance. We talked rather than rushed. She had already tried cutting out obvious foods, but still felt uncomfortable. We focused first on what she did with her mouth, her breath, and her body around eating. By the second week, she told me the same tightness had decreased. She was leaving the table lighter, and she'd sat through a birthday dinner without panicking. That kind of change is what I aim for with every person I see. First, breathe through your nose. Mouth breathing, chewing with the mouth partly open, or chronic oral breathing sends extra air down your throat and into the gut. Make a small habit of checking in during the day. When you notice airiness or fullness, place a fingertip on your upper lip and see if you're breathing there. If so, gently switch to nasal breathing. During meals, this is especially important. Nasal breathing reduces the amount of air you swallow. Second, chew deliberately. Rushed chewing invites air and forces the stomach to work harder. Try to make each mouthful thorough. The goal is to reduce large pieces of food and to mix food with saliva.
As a practical guide, aim for many chews per bite. A useful mental target is around 20 chews for a typical mouthful. But more important is the habit of slowing down until the food is easily swallowed and feels softer. This also gives early signals to your gut hormones and tends to reduce overeating. Third, avoid talking while chewing and avoid continuous sipping during the meal. Talking with a full mouth, laughing mid-bite, or sipping a drink while your mouth is full are simple ways we invite air in. Decide to finish swallowing, then speak. Take a sip between bites rather than constantly nursing a drink. If you have carbonated drinks or beer, know that the bubbles add gas volume. Sensitive individuals usually do better limiting these. Fourth, adopt a brief post-meal routine. A short 5 to 10-minute walk after eating stimulates intestinal movement, the peristaltic wave, and helps move gas along rather than letting it collect. Daily moderate exercise, like 30 minutes of brisk walking overall, improves bowel transit and reduces the tendency to retain gas over time. Movement is plumbing. If the pipes move, they empty more reliably. Fifth, set a morning hydration habit. Many patients benefit from an initial bolus of water on waking that activates a bowel reflex. I describe this to patients as roughly half to 3/4 of a liter, about 500 to 650 milliliters, as a clinician habit some people find helpful. Individualize to how you tolerate fluids. Sip slowly if a large volume feels uncomfortable at first. Hydration supports stool bulk and motility, which reduces the chance of retained gas. Sixth, reduce excessive fried and very fatty meals and be mindful of dairy. If you suspect lactose intolerance, try a careful, temporary reduction in lactose-containing foods to see whether symptoms change, and discuss testing with your clinician. Avoid extreme diet fads. Instead, reduce specific items if you notice they trigger you. For many sensitive people, refined white flour in large quantities, heavy sauces, and very concentrated carbohydrate meals can feel worse. Balance and moderation are the goals. Seventh, be aware of common triggers that often worsen gas in susceptible people. These include beer and other yeast-containing drinks, cruciferous vegetables like cabbage and broccoli, noting that cooking often reduces their gas potential, legumes such as beans and lentils, corn and popcorn, peanuts in some individuals, certain fermented cabbage dishes, concentrated tomato sauces, and some fruit juices like grape juice. I say common triggers for sensitive individuals because not everyone will react the same way. You don't have to eliminate these forever, but try short, controlled reductions to identify personal triggers. Eighth, consider probiotics cautiously and in consultation with your clinician.
In patients whose symptoms seem linked to an imbalance in the intestinal community, a capsule probiotic selected for the condition, discussed with your provider, may help. For people who are very sensitive to gas, starting with high-dose prebiotic fibers can sometimes worsen symptoms before helping. Many clinicians prefer whole bacterial probiotic capsules over large new fiber supplements in the early weeks. If a probiotic seems to help, stick with it for a reasonable trial period and reassess. Ninth, look at digestive support options under medical guidance. Digestive enzyme supplements, pancreatic enzyme support when exocrine pancreatic insufficiency is suspected, and anti-foaming agents such as simethicone are used in practice for some patients. These may help some people reduce bloating, but they are adjuncts. Discuss them with your clinician to ensure they fit your history and test results. In regions where parasitic infection is plausible, testing and targeted deworming should be considered rather than empiric treatment without evaluation. 10th, focus on stool regularity. If stools are hard, infrequent, or incomplete, gas has nowhere to go and the abdomen feels fuller. Treating constipation reduces retained gas. Simple measures like increasing fluid, gentle fiber adjustments, scheduled bathroom time, and regular movement often help. When these fail, a clinician can recommend safe, targeted therapies. Never abruptly stop prescribed medications without professional advice, but do discuss whether any of your current drugs might affect bowel function. Across all these steps, two cautions are non-negotiable. 1. If you have red flag signs, unintentional weight loss, persistent severe pain, blood with stools, recurrent vomiting, jaundice, or high fever, you need prompt medical evaluation. These signs require specialist assessment and sometimes imaging or endoscopic testing. 2. Avoid promises of immediate cures. Many patients report noticeable improvement within days for habit-related gas, and many see significant gains across several weeks when they consistently apply habits and address constipation or diet. But everyone's gut is different. If you follow the steps and do not improve, or if symptoms worsen, seek further assessment. Let me trace two brief anonymized stories because real people make abstract advice concrete. Mark, a salesperson in his 50s, had months of daytime bloating that embarrassed him in meetings. He habitually sipped cola while talking on the phone and chewed hurriedly between calls. We worked on nasal breathing, on chewing until the food was soft, and on stopping continuous sipping. He also adopted a 5-minute walk after his main meal. After 10 days, he told me he no longer left meetings early to find a bathroom, and his trousers felt comfortable again. The change was about habits, not magic. Another patient, Linda, had long periods of constipation and bloating. When we focused first on improving stool passage, more fluid, timed toilet visits, and gentle fiber adjustments, the bloating reduced because the retained stool was the main barrier to gas moving forward. Both stories show the same principle: improve clearance and reduce air entry, and symptoms often fall. You might ask about testing. If your doctor suspects an underlying organic cause, such as inflammatory bowel disease, significant biliary or pancreatic disease, fatty liver when liver tests are abnormal, or malignancy when alarm features exist, targeted tests are appropriate. These are differential possibilities, not assumptions. Lab tests, imaging, or endoscopy are tools to rule in or out specific conditions. If your symptoms began after travel or in an area where parasites are common, testing for parasitic infections is reasonable. The right tests are chosen based on your history and physical exam, not by guessing. There are a few quick practical actions I want you to be able to do in the next 24 hours. First, at your next meal, take a mental note. Breathe through your nose and slow down. Second, try counting your chews on 3 successive mouthfuls to find a comfortable target. Aim to chew until the food feels notably softer. Third, after your next main meal, take a 5 to 10 minute walk around the block. These 3 simple moves are often the first dominoes to fall in the right direction. Emotionally, I know the shame and social avoidance that gas and bloating create. People stop going out, avoid intimacy, or choose restrictive diets that isolate them. I say this without judgment. These reactions are understandable. What matters is the small, consistent actions that restore control. Start small, track changes, and bring observations to your clinician. You are not failing if the first strategy doesn't solve everything. It's data. We use that data to refine the plan. When you try changes, keep a short diary for a week. Note what you ate, whether you breathed through your nose, how long you chewed, whether you walked after eating, and whether you felt bloated later. That diary helps your provider identify patterns. If you begin a probiotic or a supplement, record the start date and any shifts in symptoms, and always discuss those additions with your doctor, particularly if you are on immunosuppressive drugs or have complex medical history. There are therapies beyond lifestyle when indicated. For example, in selected cases where a clear fermentative pattern is identified, short trials of targeted dietary adjustments, such as a supervised limited low FODMAP approach, can reduce fermentative gas. Such diets are best done with professional support to avoid unnecessary restriction. In rare, carefully selected patients with structural issues, procedural or surgical options may enter the conversation. But those are exceptions and require specialist evaluation. To recap simply and practically, nasal breathing, deliberate chewing, avoid talking while chewing and continuous sipping, take a short walk after meals and aim for 30 minutes of daily moderate activity, consider a morning hydration habit of roughly 500 to 650 milliliters, reduce fatty fried foods and be mindful of dairy if lactose is suspected, test changes to common triggers rather than assuming you must eliminate them forever, work with your clinician on probiotics or enzymes when appropriate, and prioritize stool regularity. If you notice red flag symptoms, weight loss, blood, severe pain, jaundice, persistent vomiting, or high fever, seek prompt medical evaluation. If this guidance helped you, subscribe, like, and share so other people who are struggling can find practical relief. You can also join our Telegram group for free day-to-day tips and follow on Instagram for short practical reminders. I'll leave you with this. Small, consistent habits change how the gut handles air and stool, and many people feel markedly better within days to weeks when they commit to those habits. If you want personalized guidance, make an appointment with a clinician who knows your history. Take the first step at your next meal. Breathe through your nose, chew slowly, and then go for a short walk. You might be surprised at how quickly the tightness eases. Thank you for trusting this guidance. Take care of yourself and seek help if red flags appear. If you have questions about how to try these steps safely with your medical history, talk to your clinician. See you soon.